Hello, this is Doug Boyce with North Country EMS. Going to be talking about tachyarrhythmias for the August 2014 PCEP. Our objectives for this PCEP will be to review basic EKG terms, parameters, and concepts, identify different types of tachyarrhythmias, define mild, I would like to add moderate and severe symptoms associated with dysrhythmias, determine appropriate treatments for these tachyarrhythmias, and then we're going to do some static practice on some worksheets. So we'll have a pre-test and a post-test, and then with your training officer you'll be obligated to do a dynamic megacode practice that incorporates the assessment and treatment for tachyarrhythmias. Now let's go over the provider assessment packet. This is a pre-test. Question number 1. Normal PR interval is 0.12 to 0.20 seconds. Question number 2. What is the normal QRS complex? It is less than 0.12 seconds. Question number 3. What is the normal QT interval? This varies from patient to patient depending on if they have underlying disease processes like congestive heart failure or COPD. The normal QT interval is usually about 420 milliseconds. That's 0.42 seconds. And obviously this will vary depending on if their heart rate is faster or not. There is a calculation that you can find the normal or the standard QT interval. It is the QT interval divided by the square root of the R to R. There's one easy way of finding out this information. It is actually doing a 12 lead on the patient. This will give you a lot of good information in the top left part information section in your 12 lead. We need to know the QT interval when we give a napsine, and it's actually contraindication in the protocols if you don't have the EKG monitor on them and you have Benadryl. You have to have both of those in place before you give that drug. Question number 4, what does the P wave represent? The P wave represents atrial depolarization. Number 5, what does the QRS complex represent? That represents ventricular depolarization. Question number 6, what is the voltage criteria for LVH, left ventricular hypertrophy? There's a couple different ways to actually determine this, and one of them approved by Dr. Wewer, and it's seemingly one of the easiest ways to find out if you have LVH. The S wave in V1 plus the R wave in V5 or V6. You can't choose both of those. It's S wave in V1 and the R wave in V5 or V6. Greater than 35 millimeters, which is 7 boxes, you actually have a suggested left ventricular hypertrophy. If you have greater than 40 millimeters, which is 8 boxes, you actually have diagnostic LVH. Question number 7, what EKG is this? This is a sinus rhythm. We can see P waves there, but why do we have a wide QRS? Well, we have a wide QRS because we have an aberrant conduction, and this could be caused by a lot of different things. Question number 8, what rhythm is that? The standard sawtooth show there. What is the rate? It's around 150, so automatically we'll know that's a 2-to-1 conduction. If you had a 1-to-1 conduction on a flutter, you'd be running around 300. Question number 9, what rhythm is this? This is a sinus rhythm. As you can see, there's a P wave and a QRS complex after the P waves, but you have some complexes that don't have P waves. Those are considered premature atrial contractions. Question number 10, what rhythm is this? The rate is about 210 to 220. This is considered supraventricular tachycardia. As you can tell, it is narrow in origin. Question number 11, what EKG is this? This is VTAC, wide complex, and meets the criteria for the rate. And question number 12, what is this rhythm? This is also the same as question number 11. This is VTAC. When I was doing my research for this PCEP topic, I came across this spreadsheet from Dr. Venkansan from the Madras Medical College. This is included in your student packet. This shows the representation of tachyarrhythms and where the electrical rate probably originates from. I'm a visual person, and this shows me a few things. One, that most rates around 190 and below originate above the AV node. That's shown in green. Number two, it gives you an assumption of types of tachyarrhythms, the rate, and what types of rhythms they actually are. For example, is it sinus, or is it a reentry in nature, as seen in the I think boxes. And thirdly, it shows the rates above 190 or more than likely ventricular in origin, shown in red. As this spreadsheet shows rates and possibilities, later we'll further add these assumptions by including patients' past medical history and other factors to determine origin, and then ultimately the correct treatment for these patients. Here are the classifications of tachyarrhythmias. You have two major categories. You have narrow QRS complex and wide QRS complex tachyarrhythmias. The QRS less than 0.12 would be the narrow, and wider than 0.12 would be the wide QRS complex. Narrow complexes are then broken down into subcategories: sinus tachycardias, AFib, A-Flutter, PSVT, which is broken down into AV NRT, and we'll talk about that later, and then atrial tachycardias. Wide complex tachycardias are broken down into VTACs, then the VFibs, sinus tach with aberrancy, WPW, which is a Preexcitation tachycardia, and ventricular paced rhythms. I created this fairly simple to follow algorithm to represent assessments and specific approaches to patients in tachyarrhythmias. As a general rule, patients that are normally healthy and that are having an isolated cardiac condition usually do not typically have serious signs and symptoms with their heart rates less than 150. As usual, the standard initial assessment should be done to include ABCs, oxygen are all patients that need it, and obviously applying the heart monitor. Don't forget other typically needed vital signs like lung sounds and maybe end-tidal CO2. This is the big question. As shown in the middle decision tree, is the tachycardia causing the symptoms? I generally put my patient's symptoms in three categories: mild, moderate, and severe. This typically helps guide me in the direction of treatment by how bad the symptoms are. Mild symptoms are usually isolated to one item, for example dizziness or maybe even feeling weak. Moderate symptoms are usually isolated as well. They are usually more serious ones like shortness of breath or chest pain. And severe symptoms are usually compounded mild symptoms or obvious critical ones like hypotension, altered mental status, shocky, which is the cool pale diaphoretic patient, or they show signs of heart failure with like pulmonary edema. If your patient presents with severe signs or symptoms, or even two or more of the moderate symptoms, you should go immediately to synchronized cardioversion. As usual, consider sedation prior to causing the patient's pain, but don't wait if the patient needs an intervention. As the AHA standards dictate, if you are on the fence of the patient's severity and you have IV access, you may give them a round of adenosine to see if the rhythm converts, usually only if you can tell if it's narrow or not. This may be used as a tool to evaluate an underlying rhythm or change your treatment plan. We will talk later about treatment of electricity versus giving treatment of pro-arrhythmic drugs later. Now we travel to the no, the tachycardia is not causing symptoms area. This represents a fairly stable patient. You must first identify the QRS complex, either narrow or wide. One easy place to get this information, other than counting the boxes, is using the information box on the top of the 12 lead. If the patient's in a wide complex, you give 150 milligrams of amiodarone over 10 minutes. I usually put a 150 milligrams in a 100 milliliter bag with a 60 drip set. I run 1 drop a second, and that gives me my amiodarone over 10 minutes. You can repeat times 1 if persistent. If those treatments didn't work, Or if you think this patient could benefit early from MAG, you can give 2 grams over 5 to 20 minutes. The same delivery method I use as above. If this rhythm is narrow, you can start vagal maneuvers simultaneously to other interventions, like starting an IV, and then give your adenosine regimen. If those are refractory or you see an underlying rhythm that would benefit from calcium channel blocker, you can give diltiazem. Remember, if you give diltiazem and your patient becomes hypotensive, you should give 500 milligrams slow IV push, at least over 10 minutes of calcium chloride. Supraventricular tachycardia terminology. QRS complexes typically are narrow, less than 0.12 seconds. That's 3 small boxes. Usually SVTs are paroxysmal, which is starting and stopping abruptly, which is usually why they're called PSVT instead of just SVT. The PR intervals are typically less than 0.2 seconds. That's 1 big box or 5 small boxes. Cardiac causes of tachycardias are ischemic heart disease, valvular heart disease, heart failure, cardiomyopathy, or congenital heart disease. Extra cardiac causes can be drugs, alcohol, stimulants, for example caffeine, stress, hyperthyroidism, or metabolic issues like hyperkalemia. Sinus tachycardia is a heart rate of 100 to about 180, no more than about 190 beats per minute. That's because the SA node won't go faster than 190 beats per minute. The common etiologies for sinus tach are normal exercise, dehydration, sepsis, fever, hypovolemia, anxiety, hyperthyroidism, and anemia. Atrial flutter is a common abnormal heart rhythm similar to atrial fibrillation, which is the most common abnormal heart rhythm. Both conditions are types of supraventricular tachycardias. However, A-flutter has a specific foci in the atria, whereas AFib is erratic. The causes of atrial flutter are caused by abnormalities or diseases of the heart, by a disease elsewhere in the body that affects the body, or by consumption of substances that change the way electrical impulses are transmitted. In some people, no underlying cause is found. The electrical signal that causes a flutter circulates in an organized, predictable pattern. This means that people with a flutter usually continue to have a steady heartbeat, even though it is faster than normal. It is possible that people with a flutter may feel no symptoms at all. Others do experience symptoms, which may include heart palpitations, fast steady pulse, shortness of breath, trouble with everyday exercises or activities, pain, pressure, tightness, or discomfort in your chest, or dizziness, lightheadedness, or even fainting. The atria can have an unorganized rate of anywhere from 3 to 400 beats per minute. However, the AV node can slow that conduction. As you can see in this slide, a 2-to-1 conduction cuts the atrial maximum rate by 2, hence the 2-to-1 conduction. If the AV node cannot slow the rate, a dangerous 1-to-1 conduction may occur. Atrial flutter is considerably more sensitive to electrical direct current cardioversion than atrial fibrillation, and usually requires a lower energy shock. In Clark County, our joule setting is a biphasic machine at 100 joules. A flutter is relatively resistant to chemical cardioversion and often deteriorates into atrial fibrillation prior to spontaneous return to a sinus rhythm. Clark protocol is for A flutter are the same. As long as they have no hypotension, you can give diltiazem at 0.25 milligrams per kilogram, maximum of 20 milligrams over 2 minutes. And you want to avoid this in patients with beta blockers. This is also contraindicated in patients with WPW. You do not want to give an AV node blocker to these patients. After 15 minutes, you can repeat a diltiazem dose regimen of 0.35 milligrams per kilogram and a max of 25 milligrams. If conversion of the rate or the rhythm, you can give the patient a maintenance drip of 10 milligrams per hour. If you have hypotension after the diltiazem, give 250 to 500 milligrams of calcium chloride, slow with a fluid bolus as needed. And as usual, if the patient's unstable, you continue your cardioversion of 100, 150, 200, and 200 joules biphasic. Atrial fibrillation is the most common irregular heart rhythm that starts in the atria. Instead of the SA node directing the electrical rhythm, many different impulses rapidly fire at once, causing a very fast, chaotic rhythm in the atria. Because the electrical impulses are so fast and chaotic, the atria cannot contract and or squeeze blood effectively into the ventricle. Atrial fibrillation with rapid ventricular response, also called AFib with RVR, can be very subtle, and usually the heart rhythm is anywhere from 150 to 200 beats per minute. Another assessment tool that you have is doing a thorough patient assessment. It is very clinically significant to find new onsets of cardiac dysrhythmias like AFib and Flutter, because it may precipitate myocardial ischemia or heart failure. And the chronic uncontrolled rate may induce cardiomyopathy or even heart failure. So doing a good history is very important. And as you know, both can predispose the patient to thromboembolic strokes. It's important to identify rhythms or events, cardiac events, that may induce other problems. PACs may be secondary to endogenous factors such as fever, hypovolemia, or hyperthyroidism, but more often they are secondary to exogenous factors such as medications, various stimulants such as caffeine, ephedrine-based, or even methamphetamines. You always treat as sinus tach and treat the underlying causes. This may be a precursor to atrial tachyarrhythmias, as you'll see in the video in the next slide. Supraventricular tachycardia is a rapid heart rate originating in the atrioventricular node. Usually when SVT is mentioned, this is describing AV nodal reentrant tachycardia and not the standard atrial tachycardias. This terminology can be confusing, however, understand that SVT is caused by one of two mechanisms: reentry and automaticity. Reentry is usually an AV nodal reentrant tachycardia and usually has an immediate onset with sudden increase in heart rate. Automaticity PSVT is usually a gradual increase in heart rate and is due to an area of the heart that generates its own electrical signal. Think of it as being caused by the autonomic nervous system to compensate for something happening in the body. Watch this video on AV junctional reentrant tachycardias and how they occur.
Before we go on to explain the mechanism of AV nodal reentrant tachycardia, we need to look at the structure of the junctional region in a little more detail. Atrial depolarization is conducted into the AV node by a specialized tract of conducting tissue. In 90% of individuals, this tract is singular. 10% of subjects, however, are born with two tracts leading into the node, and crucially, these tracts have differing electrical properties. One depolarizes and repolarizes at a normal rate, while the other transmits depolarizing current abnormally slowly, but repolarizes abnormally rapidly. A situation such as this, where two conducting tissues with differing electrical properties are in communication within the heart, is the basis of all reentrant arrhythmias. This situation is an accident waiting to happen. To explain why, we will focus in on events in the region of the AV node during the cardiac cycle. This close-up of the junctional region shows the two tracts leading into the AV node through the surrounding non-conducting tissue, shown here in black. The diagram also shows the proximal portion of the bundle of His and a small portion of the atrioventricular septum. Depolarization will approach the node from the atrial myocardium above. During the normal cardiac cycle, the SA node discharges and the depolarizing current generated travels through the atria to reach the region of the AV node. We will now slow down events at the node to aid comprehension. Depolarizing current enters both the normal and abnormal tract. The depolarization wave is transmitted through the normal conducting tract at an appropriate rate and depolarizes the node. Atrial depolarizing current has also entered the abnormal tract and begins its relatively slow journey through this tissue. However, at this point, current flowing in the normal conducting tissue has already reached the distal end of the abnormal strand and is conducted in a retrograde direction into this tissue. The two currents in the abnormal strand meet at some point and obliterate one another. The small, short-lived currents in this tiny strand of abnormal tissue are not detected by the ECG machine, so absolutely no abnormality is detected on such an individual's resting ECG in sinus rhythm. Following these events, the normal tract goes through a normal period of repolarization, while the abnormal tract repolarizes rapidly. With the heart in normal sinus rhythm, this process is repeated with every sinus discharge, and the existence of the abnormal tract has no consequences whatsoever for the subject. However, if the individual experiences a premature atrial ectopic and atrial depolarization reaches the tracts at this point, the effect can be dramatic. The ectopic discharge has arrived at a time when the normal conducting tissue of the node is in a state refractory to the transmission of current. The abnormally rapidly repolarizing tissue of the diseased section, however, permits current to pass. Now, the slow passage of current through the abnormal section allows enough time for the normal tract to repolarize, and current arriving at the distal end of the abnormal tract is propagated not only into the AV node and into the ventricles, but also in a retrograde direction by the normal conducting strand. By the time the current reaches the proximal end of the normal tract, the rapidly repolarizing diseased section is ready to conduct again. In this way, a cycle of circulating current is established. In the small area of the junctional region, the combination of an unfortunately timed atrial ectopic and the existence of conducting tissues with opposite electrical properties has established a rapidly discharging, self-sustaining reentrant loop of depolarizing current, which is discharging distally into the ventricles via the bundle of His, and also in a retrograde fashion into the atria. This is a micro-reentrant circuit occurring over a small area, and the small currents involved have no influence on the resting ECG. As the current is transmitted to the ventricles by the bundle of His, during such an attack we see a tachycardia with narrow QRS complexes. In addition, rapid retrograde depolarization of the atria is occurring, overriding SA node discharge. AV nodal reentrant tachycardia generates a heart rate greater than 130 beats per minute, and often much more rapid than this. In a junctional tachycardia arising secondary to a focus of increased automaticity, the rate tends to lie between 100 and 140 beats per minute. Note therefore that with tachyarrhythmias arising in the junctional region, the heart rate allows us to make an assumption about the mechanism generating the arrhythmia. A tachycardia originating in the junctional region with a rate greater than 140 beats per minute is certainly AV nodal reentrant tachycardia, while if the rate is less than 130 beats per minute, the tachyarrhythmia is labelled junctional. You will appreciate that there is a grey area. Rates between 130 and 140 beats per minute may or may not be due to a reentrant mechanism. As we'll see in the quiz section, whether we label such an arrhythmia as AV nodal reentrant tachycardia or junctional tachycardia is largely determined by the clinical context, and a definitive answer may require further investigation. The second doctor the young lady in the case study consulted spotted all the signs and made the correct diagnosis of AV nodal reentrant tachycardia. The clinical history of paroxysmal episodes is typical, and a normal resting ECG is expected. In addition, the doctor noted on both the 12-lead ECG obtained during the attack and on the patient's monitor the presence of small slurred S waves in lead 2. In fact, these are pseudo S waves and represent P wave activity as atrial depolarization is spreading upwards from the junctional region and is occurring after ventricular depolarization. The complete absence of S wave activity in lead 2 in the pre and post attack ECGs supports the contention that these are indeed pseudo S waves. As we've seen, this pattern of atrial depolarization supports the contention that the abnormal depolarization focus is junctional in location. At a heart rate greater than 140 beats per minute, the nature of the depolarizing focus within the junctional region is reentrant. This tachyarrhythmia is AVNRT. It is also worth noting that the readout from the patient's monitor captured the moment of transition from sinus rhythm to tachycardia and is very telling. Freezing at this point, we can clearly identify the premature atrial ectopic which triggered the arrhythmia.
A second pathway for conduction between the two other than the AV node. This causes recognizable changes in the EKG and can lead to wide and narrow QRS changes. In rare occasions, WPW can deteriorate into VF due to non-conventional aberrant ventricular conduction. AV node blockers should be avoided in atrial fibrillation and atrial flutter with WPW or a history of it. This includes adenosine, diltiazem, verapamil, or other calcium channel blockers or beta blockers. They can exacerbate the syndrome by blocking the heart's normal electrical pathway, therefore favoring a 1-to-1 atrial to ventricular conduction through the pre-excitation pathway, potentially leading to unstable ventricular arrhythmias. The clinical significance of AV junctional reentrant tachycardias is that they're rarely life-threatening. However, they may produce serious symptoms like dizziness or syncope. Many can be very disruptive to a quality of life. Involvement of an accessory pathway can carry extra risk. The only real treatment to these syndromes is to have an ablation surgery. AV node blockers should be avoided with WPW or history of it, so the treatment of choice with a symptomatic patient is synchronized cardioversion. As you can see here in the AHA algorithm, treatment of stable reentry SVT is vagal maneuvers and adenosine. Those are both the preferred initial therapeutic choices. However, if the patient is symptomatic, you can choose to do synchronized cardioversion first. It is important to determine the AV nodal participation in SVT by transiently depressing the AV nodal conduction. You can do this by using vagal maneuvers, which is the carotid sinus massage, Valsalva maneuvers, bearing down, blowing through a 3 ml syringe, like trying to push out the stopper, blowing through a small straw, grunting, also doing ice packs on the face, or using adenosine regimen of 6, 12, and 12. Important to note, if the SVT breaks, it's probably a reentrant mechanism. So that's the usual sudden onset one. So it's AV nodal reentry tachycardia. This identifies the likelihood that the treatment with medications or cardioversion is needed. If the atrial rate is unchanged, but the ventricular rate slows, it's likely standard run-of-the-mill SVT. The treatment of the underlying cause and the approach to the care of this is for the underlying rhythm, unless it's symptomatic or recurrent. Ventricular tachycardia or ventricular fibrillation causes most of the sudden cardiac deaths in the United States at an estimated rate of approximately 300,000 deaths per year. VTAC refers to any rhythm faster than 100 or 120 beats per minute with 3 or more irregular beats in a row, arising distal to the bundle of His. The rhythm may arise from working ventricular myocardium, the distal conduction system, or both. In most cases of occasional PVCs, the underlying cause cannot be identified. PVCs that occur frequently or for long periods of time are more likely to be related to heart disease, an injury to the heart, or other non-cardiac conditions such as chemical imbalances in the body. Monomorphic VTAC often implies heart disease, but can sometimes be seen in structurally normal hearts. Polymorphic VTAC can result from myocardial ischemia or conditions that prolong ventricular repolarization. Also, electrolyte derangements, hypoxemia, drug toxicity can cause PVCs and VTAC. VTAC ranges from 150 to 250 beats per minute. Sustained VTAC would be a VTAC that actually lasts more than 30 seconds, or it has a significant hemodynamic compromising action. As you can see in this EKG, you will or you may see P waves, but they're not always associated with the QRS complex. Signs and symptoms for VTAC: palpitations, lightheadedness, syncope, chest pain, anxiety. Physical examination findings, usually during VTAC: hypotension, tachypnea, and may or may not have jugular vein distension. Monomorphic VTAC is a form of VTAC where the shape of each beat on an EKG match each other. A common cause is tissue scarring from a previous heart attack. Treatment for VTAC or stable VTAC is high flow oxygen, IV, 12 lead. If this patient is stable, for example, if they have a mild symptom or one mild symptom, or one moderate symptom rather, a trial of adenosine may be appropriate because monomorphic VTAC is considered regular, as opposed to irregular rhythm like polymorphic VTAC. You would give 150 milligrams of amiodarone over 10 minutes. Repeat 150 if you have a recurrent VTAC. If at any time this patient becomes unstable, hemodynamically or otherwise, you can go straight to cardioversion. And if you think this patient would benefit from mag sulfate, you may give a round of mag sulfate, 2 grams, slow IV push over 5 to 20 minutes. Polymorphic VTAC, make sure it's confirmed. You have to check your leads for artifact. Make sure you treat your patient. Requires immediate defibrillation or synchronized cardioversion if it can do that. This won't present as a stable rhythm very long. If a long QT interval was observed before the patient went into polymorphic VTAC. This is probably torsades. You may choose to immediately use mag sulfate. In absence of a prolonged QT interval, however, the most common cause of this rhythm is myocardial ischemia. The treatment for this unstable rhythm is obviously high flow to IV. You want to give Versed if you can. Don't stop treatment of cardioversion or defib if they're critical and you can't start an IV. You want to defibrillate them as quick as possible at 100, and your escalating dose is 150, 200, and 200 biphasic. If you have a recurrent VTAC or it's persistent, you can give also amiodarone of 150 milligrams over 10 minutes, prophylactically even. You repeat at 150 if it's recurrent, and if again the VTAC is refractory or torsades or a TCA overdose, you might want to go directly to the antidysrhythmic of mag sulfate, 2 grams IV slow push. Risk factors of VTAC are coronary artery disease, previous heart attack, and a family history of VTAC. Some of the causes of VTAC include structural heart disease, which can be the result of scarring from previous heart attack, ischemic heart disease, which is caused by a reduced blood supply to the heart, or acute coronary ischemia. This should be a very easy rhythm to identify. This is obviously coarse VFib. It's obviously chaotic. These are usually precipitated by VTAC. That's why when you have a patient in VTAC, you want to be very aggressive in treatment and or assessment of those patients. The initial treatment for these patients is obviously IV O2 monitor and then paddles for a quick look. You have to determine the VFib or VTAC, and you want to defibrillate at 200 joules immediately. If this is witnessed by EMS, you want to make sure you defibrillate that rhythm as soon as you identify it. You still have the preload in the heart, and you still have a wide complex tachycardia represents a unique clinical challenge for 2 reasons. 1, diagnosing the arrhythmia is difficult. Although most wide complex tachycardias are due to ventricular tachycardia, the differential diagnosis includes a variety of supraventricular tachycardias. Diagnostic algorithms are complex and imperfect. Number 2, urgent therapy is often required. Patients may be unstable at the onset of the arrhythmia or deteriorate rapidly at any time. Therapeutic decisions are further complicated by the risks associated with giving therapy for SVT to a patient who actually has VTAC. Here's some more tools to help you identify a wide complex tachycardia, a VTAC versus a supraventricular or narrow complex tachycardia. Make sure you treat the patient. Your differential diagnosis might stem from a medical history and a history of and or a present illness of that patient. When in doubt, you treat it like VTAC if you don't know. VTAC is more common in elderly patients, and history of this condition is likely, and they may be on medications for this. EKG criteria for VTAC, one simple thing, as a general you can't tell the isoelectric line on these, so it's hard to tell what your complexes are. Obviously this is wide rhythm on this slide. However, if you want to identify the full downward notch, you actually can cut that whole morphology in half, that whole one rhythm in half, and if you have less than, or rather greater than 0.06, which as you can tell is half of the wide QRS complex criteria, which is 0.12, you probably have VTAC. This is just an easy way to see half the rate from the positive downward deflection to half. Just like tools in your toolbox, here's some additional clinical clues to help you identify regular wide QRS tachycardias. Just remember, VTAC does not invariably cause hemodynamic collapse. Patients may be conscious and stable, so make sure you assess your patient, do your primary assessment, and make sure you get your first set of vital signs before you make treatment decisions. History of heart disease, especially past myocardial infarction, that suggests VTAC. Occurrence in young patients with known heart disease suggests SVT specifically. And make sure you check your 12 lead. Usually that will tell you what rhythm you're working with. And as stated before, make sure you treat your patient. If this rhythm shows up out of the blue, your patient is maybe young and they don't meet the general criteria of the patient that you would normally think is in this rhythm, or their conscience, make sure you look at your leads, see if there's any additional artifact, or you're bouncing down the road. They may be tapping or nervous. They may be tapping their leads. There's a lot of different reasons that you would have these type of artifact. Make sure you check your patient. Here are some treatment rules for wide complex tachycardias. If they're unstable, you synchronize cardioverge them, or you defibrillate them as needed. Make sure you treat the patient, not the rhythm. Look for hyperkalemia and TCA overdose from their medical history, and or identify those early in your EKGs, peak T waves, prolonged QT intervals, etc. The QRS complex greater than 12 milliseconds is probably VTAC. AV dissociation is probably VTAC. Older patients and fast is probably VTAC. I think you can see a trend here. And if they have previous MIs and or is fast, it's probably VTAC. And then you go back to rule number 1, which is also number 8. If they're unstable, you synchronize cardiovert them or defibrillate them. And Dr. Whitwer wanted to go over the ROC and ALP study again, the amiodarone, lidocaine, or placebo study from the ROC folks. Here's the inclusion criteria for the ROC-ALP study. Inclusions are non-traumatic out-of-hospital cardiac arrest. You have to have IV or IO access. This is for persistent recurrent VFib or VTAC. So basically, if you would give amiodarone to a patient after your epi, you see another VFib and you're getting ready to shock it, now they're included after that second shock. Exclusion criteria for the ROC study would be open label IV amiodarone or lidocaine, known hypersensitivities to the drugs, amiodarone or lidocaine, or you have protected population, which is prisoners, pediatrics, or minors, patients that are pregnant, or the person is a traumatic death, and or those patients with a no-study bracelet. A frequently asked question is what counts as a shock. Obviously, first responders using the BLS, like AEDs delivering a shock, another ALS agency delivering shock, the non-ROC agency shocks or the public access defibrillators, those also count. Those defibrillators will not deliver a shock unless the patient's in VFib or VTAC, so they can still be included in this study. The internal pacemakers or defibrillators, those shocks are not included as a typical shock. What is persistent or recurrent VFib or VTAC? It's a confirmed VF or pulseless VTAC needing CPR. It can happen anytime after this first shock, and what that means is if you shock at a VFib and then the patient goes into a sinus rhythm and then again back into VTAC or VFib, that's recurrent. It's coming back. You also want to think, if I'm going to give, or I normally would give, amiodarone or an antiarrhythmic drug in your Clark County guidelines, also the AHA guidelines, that's when you would want to step in and give the ALPS drug, as long as they meet the criteria for inclusion. For credit for this PCEP, and to meet the requirements for the Clark County PCEP program, you must complete your post-test to include your rhythm interpretation and treatments associated with them, complete a megacode evaluation with ALP study scenarios and tachyarrhythmia identification and treatment. As soon as you're done with that, your training officer will deliver the appropriate paperwork to the medical director for credit. This PCEP is worth 2.5 hours of CME toward cardiac assessment and intervention for both EMTs and paramedics. Thank you for watching.